Welcome to the Green Table Talk, where we will have open and honest discussion about transplant. I'm your host, Jennen Johnson. Do you know how long your mom was living with liver failure prior to her telling the family?
The process is so foreign, right? Like, how does one get a kidney? It was so surreal.
When I was going through my kidney failure, everybody came out. Everybody had an opinion. Everybody was a doctor. And so I had a whole bunch of suggestions. Do this fast, do that fast. You gotta cleanse, you gotta juice. So my question to you is any of this real? Welcome to the Green Table Talk. My name is Jennen Johnson. As always, I'm your host. Today, we have a very interesting topic that a lot of people is interested in. We received questions, and so I actually have my list of questions here because I don't want to miss anything. Today, we have my friends, Lucia, we have Dipika, and we have Charles. Welcome to the show, everybody. So, don't be shy. You can speak up. You can say hi.
Hey, Jennen.
Hi, Charles. So, what I'd like to do is have you introduce yourselves to our audience. Let's start with you, Lucia.
Sure. My name is Lucia Anghelache. I work as a medication reimbursement specialist for the Jumeirah Transplant Center at the Toronto General Hospital. And my job is to ensure that patients have access to their prescribed medications after the transplant surgery. I also work with pre-transplant patients, mostly from out of province, but also local patients who may have trouble securing coverage for their medications.
Beautiful, beautiful. Welcome. Thank you for joining us. And Dipika, let's hear a little bit about you.
I am an inpatient clinical pharmacist. I work also at the Jumeirah Transplant Center with all organ groups. So we work with patients that have had or are having kidney transplants, liver transplants, heart transplants, lung transplants, pancreas transplants, sometimes small bowel transplants. We work to ensure that patients are getting the right medications. We work with teaching patients about these new medications with staff members and different healthcare professionals, educating them about the medications and dosing and therapeutic drug monitoring. All very rewarding.
Beautiful, beautiful. That sounds like it's very rewarding, definitely.
For sure.
Thank you very much for joining. And last but not least, we have Charles. So give us a little bit of background information for yourself.
Sure. I'm Charles Cook. I'm a two-time transplant recipient. I received a heart in 2016, received my kidney in 2017. I've been taking immunosuppressants and all other kinds of drugs since I had a massive stroke back in 2005. And so these ladies have helped me along my journey very much. And I'm very pleased to be here to be part of the conversation.
Excellent. Thank you for joining. Now, I was just so excited to get this, this started. I didn't even tell you what our topic was for the day. Everybody kind of touched upon it, but I will put it out there. We are talking about transplant medications. We are going to cover the gambit of transplant medications, costs, side effects. We have, like I said, we got lots of questions here. So let's get it started. Okay. So our first question. What are the differences between the medications taken before and after transplant? I'm going to give that to you, Dipika.
Thanks, Jennen. So before transplant, so depending on what your failing organ is, you're going to be on medications that are helping you overcome that kind of failure. So if your heart is failing, you're going to probably be on medications that are helping with heart failure, that are helping your heart contract more, that are helping you get rid of fluids more. If your organ that's failing is your lungs, you're going to be on medications that are helping you breathe or are decreasing inflammation in your lungs, or inhalers or different steroids to decrease inflammation. If your liver is failing, you're going to be on medications that are helping you reduce the risk of encephalopathy, or helping you, again, like you have a lot of fluid retention when your liver is not working. So all those medications to help counteract what's not working. Yes. On the flip side, after the transplant, you've got a new organ that's working now. You've taken that organ away that's not working, and you've got this new, beautiful, precious organ, but you've got to take medications that are suppressing your body's immunity or ability to fight or attack the new organ. So you want to prevent the phenomenon called rejection. So that's the difference.
Okay. Okay. Yes. I remember when I was going through my transplant journey, and I heard a lot about rejection, and I heard, you have to take your medications, and, you still have to eat a certain way, and you can't just go back to, eating a whole bunch of junk food and what have you. So
Moderation.
Yes, of course. Right.
Yeah. Yeah.
Beautiful. My next question, what kind of side effects do patients commonly experience? I'll give that to you as well, Dipika.
So there's a lot of different medications that you're going to be on after transplant. So side effects after transplant medications, yeah?
Yes.
Each different medication comes with its different benefits or efficacy, along with some side effects. Side effects happen in some people and they don't happen in others. It's very individualized. A class of medications called calcineurin inhibitors, like cyclosporin or tacrolimus, that patients might be on, one or the other. They can cause perhaps increased blood pressure. They can cause increased blood sugar. They can cause a mild tremor or trembling of the hands. Another class of medications that patients are on are called steroids. So the most common one that we send patients home on is called prednisone. Prednisone can cause fluid retention. I see Charles smiling. He wants to talk about what happened to him with prednisone, because the side effects can be very, very marked in some individuals over others.
Mm-hmm. And you gain a lot of weight at times too when you're on prednisone. I could fight that as well, right? So, yeah. Sorry, Charles, you want to speak on this?
Sure. A couple of great points have been made. First and foremost is that all of this stuff is individualized because everybody's body reacts different, and the cocktail of medications that I take will be different from you and from whoever else is watching this.
Yes.
And then, so the side effects are different because the drugs affect everybody's body differently.
Mm-hmm.
My particular case, prednisone, the one I took prednisone after my heart transplant, had no issues with it whatsoever, except the mood swings. It was kind of like I had roid rage, and I didn't know what was going on. And I remember my wife being in the car one time driving home from Toronto General, yelling at each other. And she's like, "What's wrong with you?" I'm like, "I don't know. What's wrong with you?" And so then I talked to my transplant coordinator, and she said, yes, mood swings are a common occurrence with that drug. And I thought, well, that might have been something that would be good to know. So I'm telling people now that are watching this, that if that happens to you, then you're not alone.
Mm-hmm.
A more interesting and kind of a longer story about prednisone, if now is the time for me to tell it, I'll get
into. Of course,
into.
definitely. Yeah.
Okay. All right. So when I had my kidney transplant, which was about 1.5 years after my heart transplant, they put me on high dose prednisone. And right after your transplant is when they give you the highest dose normally, to help protect rejection and to help your immune system, that kind of stuff, what you have left.
Yes. So
they were very concerned about one of the effects that was mentioned is that prednisone can knock your blood sugar out of whack. So they told me that I was pre-diabetic. It's like, aren't we all, pre-diabetic? I didn't really understand what that meant. And they were monitoring my blood sugar very closely. And I think I was on maybe 100 milligrams for 4 days. And then that was it. And then, I never became diabetic or anything like that. So it's okay, that's fine. We fast forward to 2018 and found out that I had polyomavirus BK developed after my new kidney. And so what they wanted to do was to give my immune system a chance to fight off the infection on my own. So they took away one of my immunosuppressant drugs called Myfortic. Myfortic went away. My immune system came up, fought off the BK virus, great. But then when I had my next biopsy for my heart, guess what? If you take away anti-rejection medication from someone who needs anti-rejection medication, then you get rejection. So my heart was rejection. And they said, we can't have that. So it's a balancing act between the heart and the kidney. And again, this is all individualized. So the plan was to switch me to another immunosuppressant, which was more kidney friendly, but still provide the same protection for my heart. This drug was called sirolimus. sirolimus went along fine. I guess I should say when I had my heart transplant, when the new heart was connected to the old plumbing, my aortic valve was damaged. And so since my transplant in April of 2016, every 3 months, I've gotten a heart biopsy basically and an echocardiogram, because one of the effects of the heart, or that you can tell that the heart is in trouble, is that it'll start getting bigger to pump more blood because you're losing some because my aortic valve is damaged and leaking. So went along with the with the sirolimus. And then in the summer of 2019, they'd done an echo and said, it looks like your heart is enlarging. We might need to do something with your aortic valve. Now might be the time for the surgery.
Oh
and goodness. What they wanted to do was to get just a scan to make sure everything else was going well. So I did an MRI on my chest, and they found a sort of pneumonia in there. When you look at the film, it just looks milky, like it's really cloudy, like my lungs aren't clear. Mm-hmm. So they said, you have a lung disease, and it's very rare. Again, an individualized thing. My transplant coordinator has been doing this for somewhere between 30 and 40 years. And she said that I'm the 4th patient that she's ever seen with it. So lucky me, if you can get it, I will. And the treatment for this lung disease is high doses of prednisone. So they put me on 60 milligrams of prednisone, and then we were basically going every 6 weeks and getting another MRI. And as the lungs cleared up, then we would reduce the dosage of prednisone. 2 things happened. First, the concern about my sugars getting out of whack actually came to pass. And I had gone to do regular blood work, and I got home, and results usually come in about 6 o'clock in the evening, and you can check it on Life Labs through your computer. And I actually got a call before I checked my results that night. And it was Dr. Cole from TGH. And he said, we got your blood work results back. Your blood glucose is at 37. This is very dangerous. You don't have time to mess around with this. You need to get yourself to an emergency room. And he said, you have the choice of either going to your local emergency room. I live here in Kitchener, so Grand River Hospital is right down the street, or you can drive to TGH. And I said, I think if it's an emergency, I'll go to Grand River. So I went there. By the time I got an emergency and they took my blood glucose, they just have the monitors that say 34, over 34, which is the amount
out of range.
Right, exactly. By the time they actually got me upstairs into a room and were able to take it out of my arm, my blood glucose was 52.
Oh my goodness.
My blood was basically syrup, and it was, I was circling the drain at that point. I spent the next 4 days in ICU. And when I came out on the weekend, I was an insulin dependent diabetic. And I had to deal with that up until the fall of the following year. But the good news is that we got through all of that. My diabetes is now in remission. As the lungs cleared up, the prednisone, because we knew what the cause of the diabetes was, I had to do, 2 types of insulin to regulate the blood sugars, which was not fun, but I did get through it. Unfortunately, I had a good team, the Diabetes Education Center, both here at Grand River and at TGH. They helped me out and helped me, get through it. But it's just one of those things. It's not something that happens to everyone, but it happened to me. And if it happens to you, then, you're the one patient that you're responsible for. So you need to have a team behind you. And I definitely feel that I have that. So everything is well. I'm sitting here now, I'm doing pretty good.
You need to write a book, Charles. Like, that's just like your story. That's just damned if you do, damned if you don't, but I made it out on top. You know what I mean? Like, that was just,
you just hang in there and keep banging,
That's it. That's all you can do. Literally, that's all you can do.
Yeah.
Thank you for sharing, Charles, that experience with us. Now, my next question, what are common medication regimens for transplant patients? Dipika?
So, usually patients are on 2 to 3 anti-rejection medications post-transplant. So we talked about just previously a calcineurin inhibitor, so either cyclosporin or tacrolimus, and then a steroid. So that would be 2, prednisone, which Charles loves. And a third one could be, they're called antiproliferative. So azathioprine, which is an older medication that some patients are on, or mycophenolate or Myfortic, which Charles alluded to as well. So that's a 3-drug regimen. Okay. It's quite common. Some patients can get away, depending on their immune risk, with just the 2-drug regimen, so the calcineurin inhibitor and the steroid. And then sometimes over time, the prednisone dose is tapered down as low as we can get it, because we know that prednisone comes with side effects.
Yes.
And then plus or minus Myfortic if needed. So that is an anti-rejection regimen. Then anti-infection. So as we know, immunosuppressants are suppressing your body's immunity or your ability to attack the organ and to fight off against regular infections. So opportunistic infections, or like weak little bugs that are in the air that might not affect or harm non-immune suppressed patients, will harm immune suppressed patients. So patients are prescribed something to prevent against a certain kind of pneumonia. So this medication is called Septra. If someone's, or sulfamethoxazole trimethoprim, that's a tongue twister.
Say that 3 times fast.
Yeah. Or some patients who are allergic to this medication are prescribed something else called perhaps Dapsone or atovaquone. And then sometimes we have to put patients on a certain antivirus medication called valganciclovir, or a brand name called Valsite. And that prevents against a virus in the herpes family called cytomegalovirus, another tongue twister. And sometimes we give patients are at risk for herpes infection, so they'll be on something else called acyclovir. And lastly, we want to prevent against a fungus infection in the mouth, commonly known as thrush, or an overgrowth, like white itchy plaques in the mouth. Charles is smiling. And so tell me, you probably had thrush with high dose of prednisone, did you not?
I did indeed.
Oh, there you go. So we don't want that to happen. We give you, in most cases, nystatin is sufficient to prevent the infection from happening. And if the infection does happen and get more severe, we have to maybe prescribe a more potent antifungus medication. Okay. These anti-infection medications are sometimes not forever. We can stop them once we get your immunosuppression down to a certain acceptable level.
Gotcha. Okay. Yeah. So to find out, if it's time to, get off these medications, or not the medications, but to help reduce the thrush and what have you, if you do get it, the doctor will then tell you when it's time to come off of that particular medication or whatever it is. Okay, gotcha.
Yeah. Usually once your prednisone dose is down to a low dose, a rule of thumb is usually by 3 months. Post-transplant, patients don't need to use nystatin regularly anymore.
Gotcha. Okay. Yeah. My next question, can a transplant patient use generic medications instead of brand name medication?
This is a very good and loaded question. It also segues into a lot of what Lucia is going to talk about for drug coverage. So I'm sure everyone is on different types of generic medications, maybe for blood pressure or for their mood or for diabetes. And these medications have like the drug name, the active ingredient name, and probably like a little prefix before, like APO for Apotex or Teva. So depending on the generic pharmaceutical drug company that makes the drug, okay? Then people are familiar with branded medication. So in terms of these transplant medications, a brand that we use is called Prograf, and the active ingredient of Prograf is called tacrolimus.
Yes.
Now, Prograf, tacrolimus, cyclosporin, sirolimus, these are all medications in which they're critical dose medications or critical drugs, in that we are monitoring the level of the drug in each individual. And slight dosage changes could mean a big difference in drug level in a person. We at the Edgemere Transplant Center would like that, or advocate for patients to remain on brand name medications of these critical dose immune suppressant agents and agents like, say, my Fortic that Charles was on. The generic medications, when they come to market, they're approved by Health Canada, and they have to prove something that's called bioequivalence to the brand name product. Mm-hmm. The studies to prove bioequivalence are done in a very small, maybe like up to 30, 40 healthy individuals who are not transplant recipients, who are not on any other interacting medications, who are not on any other immunosuppressants. So it's in healthy individuals. Mm-hmm. Each generic medication, so maybe the APO brand and the Teva brand, do not have to prove equivalence to each other. They just have to prove equivalence with a certain like give or take range of acceptance to the brand. Now, say if you go to a pharmacy, I hope this is making sense what I'm saying.
It is.
It makes sense in my head. If you go to a pharmacy and you are dispensed, say for example, apotacrolimus, this month you get your pills and the bottle says APO and you take it. Then the next month you go back for a refill from the pharmacy, you might get Teva tacrolimus. You're taking your dose as always, 2 milligrams twice a day, and then maybe you get blood work done, and I'm talking very hypothetically right now, you get blood work done and there could be a difference in that drug level. And the doctor's thinking, well, he's on the same dose. What's going on? Something, I'm going to increase that dose. You need 3 milligrams because your level has gone down. Now you go back to the pharmacy the next month and maybe you fill, and now you're gone back to APO. And all of a sudden your level is through the roof. So what I'm getting at is it's kind of nice or encouraged to stay on the same brand, the branded medication that we know is studied in this controlled environment in transplant patients, supported by the literature. Mm-hmm. That we know that your levels will stay where they're supposed to stay. And if there's any fluctuation, we can take the factor of the drug out of the equation.
Yes.
There's no kind of control. Like a pharmacy does not have any, sometimes no control over what generic they dispense. By law, they can dispense any generic brand that's available. So maybe there's no Teva tacrolimus available anymore. So the pharmacy is stocking Novo Farm or Jennen Farm or Apotex tacrolimus. So this uncontrolled kind of generic switching can be problematic, and we don't want that for patients. Mm-hmm. So we recommend that patients stay on brand name. We have partnerships with our pharmacy, the transplant outpatient pharmacy that's in the 12th floor clinic area of our hospital, who has kind of partnerships, agreements with the brand name pharmaceutical drug companies that we're able to give you drug reimbursement cards to pay for that difference between brand and generic, because a lot of patients' drug plans only pay for generic.
Yes.
So including our government.
Yes. So patients that are on, ODB or Trillium or social assistance, their plan only covers for the cheapest cost. Mm-hmm. We want you to be on the Prada brand. We want you to be on the brand name medication. So we'll get you those cards. For drugs that don't have such a narrow therapeutic index or who are not critical dose drugs, like medications that you're taking perhaps for blood pressure or for, water retention, something called furosemide, the risk of having a little bit up or down in that dose is not going to be critical to your organ function. It's not going to mean a difference between like a level shooting up and causing damage to your organ or a level going so down, putting you at risk of rejection, right? Mm-hmm.
So basically what I'm hearing here, Dipika, like we went through the whole process of getting this organ. We should stick to the brand names. You don't want to risk rejection. You don't want to stick to the brand names, correct?
Yeah, work with us. If you're having trouble accessing them, work with our team. We'll get you what you need.
Perfect. All right, guys, my next question. What can we do to monitor and minimize the side effects and interactions of medications that we're taking?
I think being aware of what the side effects are, so you yourself know that perhaps you're having a side effect, is key. Adhering to the regimen prescribed taking certain medications with food, without food. So one of the main side effects of prednisone is upset stomach if you take it on an empty stomach, or mood swings or sleep disturbances if you take the medication too late at night. So there you go. Take it in the morning, take it with food. There, you've knocked off 2 potential side effects. Increased blood sugar, increased blood pressure is another side effect of these medications. So knowing that those side effects could happen, there are certain lifestyle changes you can make. So controlling how much salt you're getting in your diet, controlling how many sugary foods you're having. We're not saying don't ever have them. I mean, it depends on each individual. You might be on a salt restricted diet, but you know, everything in moderation.
Of course.
I want to share my screen because just as of yesterday, we have a new and improved website, which is going to serve to provide patients with everything they need to know. Beautiful interactive modules on each anti-rejection medication, how to take them, when to take them, how to monitor, what the side effects are, what they can do to have a healthy life. I'm going to start sharing. If that's
so we've got like the inside scoop right now, Dipika, what you're saying.
This is hot off the press. So
Beautiful.
Let me try and do this. Can you guys see that okay?
Yes, we can.
So here's the website. It's TMIT, Transplant Medication Information Teaching Tool. So tmit.ca. So www.tmit.ca is the website. And if you click on the different parts of the website, it gives you information on each medication that you could be prescribed. It talks to you about why you need to take these medications. So it gives you an introduction to what the immune system is. It explains what rejection is. How do you, recognize the signs and symptoms of rejection? I'll click on that to show you. So it, it's lists it out for you, and there's beautiful pictorials to help even further explain the point. What are the signs and symptoms of infection? Why you need to take anti-infection medications? How to read a prescription label, like goes down to the basics. How to calculate your doses of medications. Managing your life post-transplant in terms of medication. So taking your medications, tips on how to remember taking your doses. What happens if you vomit after taking a dose? What do you do if you forget a dose? How to store your medications, what pain medications you can take, drug interactions. It goes on and on and on. You can tell that I'm very proud of this website.
As you should be.
All of you to spread the word and, to, navigate this site, and hopefully it helps you. Like we hope it should.
That's amazing. Congratulations on the site. I wish I had this, say, like 3-4 years ago when I was going through my transplant journey. That's great.
That's what I was thinking. It would have been great.
So Charles, do you have this book?
I do not.
Did you ever have a heart transplant, like a heart or a kidney transplant manual?
Yes, indeed.
So this is probably just the more recent version.
Never a medication workbook.
Yeah. So in here too, after transplant, we'll provide each patient with this kind of, oh my God, blast from the past word, duotang.
Oh, wow.
of what medications that you're on and how to dose them. I don't know if you can see that okay. What the medications are, how to dose them, certain information on them. So this is another, resource we give to patients post-transplant.
That is great. Wow. Congratulations on that. That's really good. Like I said, I wish I had that back then. So now that we're speaking about medications and, dosing, what happens if you miss a dose?
So we kind of like to use like a halfway point rule. If it's before the halfway point that your next dose is due, take the dose. Okay. If it's after the halfway point, don't double up, just take your next scheduled dose. And gotcha. I think it's always a good idea to let your coordinator know, because what if you're going for blood work the next day and then they get a wonky level and they're like, oh my God, we have to change it. Well, you don't want them to be changing a dose based on an error.
Yes.
Yeah.
Okay. My next question, instead of taking prescribed medications by your doctor post-transplant, is it safe to use herbs and natural remedies?
Hell no. So, no, you take the medications that are prescribed for you. You don't want to experience rejection. You don't want to have bad side effects. You don't want to be at the risk of infection. At the Ajmera Transplant Center, we actually have a link to a pamphlet or kind of like a circular for patients talking about how we don't want you to be taking herbals or natural health products, because really, have they been studied in patients who are on immune suppressants? Have they been studied? Have the drug interactions really been documented, or is there guidance on what to do with them? No. A lot of these natural products have claims that they boost the immune system. Now, is that wise? Is that what we want to be doing? No.
Exactly.
If claims are true, we don't want to be boosting the immune system. I always am wary of any product that has grandiose claims like this is going to make your hair silky and you're going to be sexy and you're going to look 20 years younger. Like, honestly, no.
That's one heck of a pill.
I know. We don't know what it's doing. We don't know what it's doing to the drugs. We don't know what it's doing to your graft. Even things like probiotics. There's different evidence coming out now about whether it's safe to take probiotics or not. A lot of patients do have chronic conditions in which they are supervised taking certain probiotic strains. We've had in the past patients, because they're immune suppressed and they're taking high doses of probiotics, that they actually get a bloodstream infection. So they get a septic infection with these probiotics seeding in their blood. So we don't recommend their use. We don't recommend the use of herbals.
Wow. Okay.
The medication's prescribed.
Exactly. The doctors know what they're doing, right? Pharmacists know what they're doing. Now, speaking of herbal and natural, let's talk about marijuana.
Okay.
Do you feel that marijuana can actually help someone that's going through their transplant journey, whether it's post-transplant, pre-transplant? Can that actually help?
More and more, we're seeing patients who are taking marijuana, whether it be prescribed or recreational. Marijuana, so THC and CBD, they do have roles in helping with pain, helping with inflammation, helping with nausea, helping in seizure disorders, helping with as an appetite stimulant. There's a lot of patients that are chronically ill and they need help.
Yes.
Now, I know that our transplant center doesn't say no. It's not outlawed. However, for use in hospital per se, prescribed licensed products that are oils are permitted for use in hospital for a medical reason. The program does not promote the use of smoked marijuana for many different reasons. I mean, carcinogen risk, and you really don't know the purity, what you're getting. So oils with a known kind of THC to CBD content. And I think an open and honest dialogue with your transplant team is necessary if you are using these products, because marijuana products are metabolized by the same set of enzymes, or enzymes meaning like engines that process your transplant medications. So maybe someone's starting or stopping, and then all of a sudden drug levels are affected. It would be nice to know why, or to see if we could help in any way or not be bewildered as to why X, Y, or Z is happening.
Yes. Okay.
Around the time of transplant, I mean, marijuana products can interact with anesthesia. They can maybe make you extra drowsy in combination with anesthetics that are needed. Sometimes patients need more anesthetic if they're chronically using marijuana. So it's an open and honest dialogue that's needed.
Yeah. So if someone's already started without asking, going through the proper channels and speak to their doctors
just
about it.
Talk to us. We're not judgy.
Yes. That's the whole point, right?
Yeah.
My next question. Can these transplant medications reduce your chances at getting pregnant? I know there's a lot of people who, at post-transplant, they think, okay, yes, I'm healthy, I'm strong, let's go start a family. Does these transplant medications affect that in any way, shape, or form?
So I can't really comment on the medications affecting fertility, but I know after transplant, the data is there that your fertility returns. So
Beautiful.
there are a lot of patients who have are successful in having beautiful, wonderful families post-transplant. Again, this is a conversation that has to happen with your transplant team, because certain medications your regimen does have to be tweaked. It should be something that's planned. Your transplant team should know that you're interested in this, and they have to assess your graft function, because if your graft isn't working where it should be, or if your doses are too high, or they're still in the process of adjusting and what's the word I'm looking for? Individualizing therapy for you, it's probably not a good time to put that extra strain on your body. But yes, patients can get pregnant. Yes, patients can have healthy, normal, beautiful children after transplant.
That's good news, because I know that's, that weighs on a lot of, people's mind,
sure.
Post-transplant.
Yeah.
So good to know. Should someone who's post-transplant and pregnant do anything different in regards to their meds?
Well, that'll be followed up by the transplant team, because they will tell you what regimen you should be on. So, I mean, not only just immunosuppressants or anti-infection medications, there's going to be a different cocktail of medications that you should be using if you're pregnant for blood pressure, because there's certain medications that are only safe in pregnancy versus some that are not. So you'll be seen by a specialist. Your whole list of medications, whether it be for your graft or your blood pressure, your blood sugar, will all be assessed in light of that. But you should never make any changes on your own.
Of course. That can be more dangerous than you actually banked on, right? So
like same goes pregnancy and lactation. So if you're breastfeeding, the same review will happen.
Okay.
Yeah.
Now let's talk about traveling. How can someone address their transplant needs when abroad for long periods of time?
Are we ever going to be able to travel again?
Fingers crossed.
Again, it's conversation with the transplant team if a patient does want to travel. So there's a few things to consider. A patient should have travel insurance.
Yes, definitely.
Right? That's really, really important. So whether it be insurance for medical care while they're abroad, or insurance for medications, patients usually fill a big slew of medications prior to leaving on a trip to the maximum that they can. And they are to take these pills with them on their carry-on. Never check these puppies in. You don't want your luggage to get lost and then you're without medications. So always in your carry-on. Take more supply than you need. You're going to probably get a transplant letter. So something from your transplant coordinator or your transplant doctor that talks about your condition, what medications that you're on, and certain contact information. So that if a patient is abroad and anything happens, then at least that medical care team abroad knows who to contact.
Gotcha. Okay.
Now, Lucia will probably talk about, maximums on how many medications you can fill, but we can.
Yeah, I can add it now if you want. Like it's up to 100 days. In each Canadian province really is up to 3 months, so up to 100 days that you can fill at a time. That's called a vacation supply. Okay. So you can take that with you.
So what if you're, sorry, go ahead. Sorry.
So I know what you're going to say. You're going to say, well, what if you're going for a really long time? So there's a few things.
Yeah, I was about to say that.
Yeah.
Like people go back.
I mean, a lot of people do. I mean, I don't want to live here in the winter.
Exactly.
No.
So what happens then?
So there's a few things. You can either fill that like through your drug plan, your 100-day supply that will bill through, or you can fill more and then you're paying out of pocket. Or if you're only going to pay that amount that's covered, you can have it shipped to you.
Okay.
Local pharmacy could do that sometimes.
Yeah.
Your local pharmacy.
Or you could invite a friend to come and visit you and bring your pills. Especially if it's somewhere hot and beautiful, invite your friend to come join you. But yeah. My husband is a transplant coordinator and he has helped ship medications to patients. I mean, last year, if you think about it, maybe patients were on trips and because of COVID, they couldn't come back. They were stuck.
Yes.
So stuff happens. You just have to be being prepared.
Okay. I'm going to switch over to my friend Lucia I haven't heard from her, so I want to like,
I'm like, I'm monopolizing. I'm so sorry.
No, that's good. You're sharing information. Knowledge is power, so there's nothing wrong with that. Trust me. Good. Lucia, approximately how much can someone pay out of pocket for transplant medications? Now, you just said you gave us a ballpark, but let's dive into that a little bit more.
Well, it depends what we're talking about here. If we're saying how much does someone pay if they don't have any drug coverage of any kind, then that's a different discussion versus someone that has coverage through a private plan, whether partial or, through the Trillium drug program, et cetera. So if someone were to pay out of pocket full cost, it could be anywhere between $1,000 to $3,000 per month, I would say. Sometimes more, sometimes even more. But if someone has partial coverage through a private plan or through the Trillium, then it would be hard for me to provide a dollar amount. Yeah,
so that's
because it does. Yeah.
That's a lot.
It is a lot.
Okay, so what type of drug programs are available or that someone can apply for? You just mentioned Trillium.
Yeah, so the I would say that the three most important ones for us are the Trillium drug program, the social assistance that is comprised of the Ontario Disability Support Program and Ontario Works, and the seniors program for those 65 and older. It's a bit different the way these programs work. The seniors program, it's, I would say, the most straightforward one because you receive a welcome package pretty much in a mail from our government. And then the coverage kicks in the first of the month following your birthday. Okay. With some differences here, some high income earners may have to pay $100 per year deductible, and a higher dispensing fee up to $6. And the lower income, they have no deductible and they pay up to $2 per prescription in dispensing fees. And some pharmacies may waive that dispensing fee. And by the way, our pharmacy, Transplant Outpatient Pharmacy, does waive that and also reduces the dispensing fee for high income seniors. Beautiful. So that's good to know. Yeah. And then the social assistance, the major difference between the Ontario Disability Support Program and Ontario Works is that for these disability support program, that program is for people with disabilities, and it could be a permanent disability or a temporary disability. There's an application process that you could do online. So that's pretty straightforward. It's no deductibles, it's full coverage. Okay. And then the Trillium program is the one that is a little more complicated because you do have to complete an application form and you actually enroll in a program, and it does take a bit of time. I would say maybe a couple of weeks, plan ahead if you need to apply to Trillium. Okay. The application can be downloaded from the government website as a PDF fillable format, so it's pretty user-friendly. Or if you don't have access to a computer or a printer, you could just get it from your local pharmacy or a social worker or myself. Provide that to you. And that one is a bit different because it does take into account everybody that lives under the same roof and shares expenses. And obviously, so if you're over 16, you must sign the form and you must provide access for the income verification with Canada Revenue Agency. So usually it is recommended that everybody does their income tax filings every single year. And that would be because it makes for a quicker and more seamless process. Now, of course, there are situations where people may be late doing their income tax or they haven't filed in a few years. I have encountered those situations. And that should not be a barrier to enroll in Trillium. It doesn't. It's not. You can still enroll. You can provide proof of income. And that is accepted. So that's not an issue. Okay. And then based on the combined household income, there's going to be a deductible that is calculated, and it's typically equivalent of 3 to 4% of the combined household income. And you pay towards that deductible when you fill prescriptions at the pharmacy. Okay. Yeah. So that is also split into 4 quarters to make it easier for people to pay towards the deductible. And so when you go to the pharmacy with your prescriptions and you keep paying and paying, but all of a sudden you don't pay anymore, that means you reached your set deductible, right? And then Trillium kicked in for you and you don't have to pay anymore. You just pay the dispensing fee, or if you come to our pharmacy, that dispensing fee may be a little reduced. That's pretty much how it works. Now, if you do have a private plan that is partial coverage, you just say 80% and you're enrolled in Trillium. Trillium is secondary payer. So you still have to go through your private plan first.
Okay.
So if your private plan is 80%, then you pay 20% at the pharmacy up front. And then you mail your receipts to Trillium.
Okay.
So it's a little more complicated for patients that have dual coverage, how we refer to them as people with dual coverage. So you have a private plan in Trillium, but it's an ideal scenario in my opinion, right? Because you have the best of both worlds.
Yes, definitely. So what happens if you apply to Trillium and the benefits doesn't kick in by the time your meds are here, you're supposed to pick them up, you're supposed to pay for them, but unfortunately Trillium didn't kick in? What happens then?
That's a good question. Yeah, that's a good question. So if that happens, you may have to pay for your medications at the pharmacy when you pick them up. However, depending on what enrollment date you chose on the application, you have an opportunity to then submit the receipts and request retroactive reimbursement from Trillium. So it really depends. When you apply to Trillium, you are to choose your enrollment date. Right? So you have to choose it very wisely, is what I'm trying to say. It should reflect the date when you actually need the program, ideally.
Okay.
Yeah. And then you have an opportunity to, even if you have to pay upfront, you submit the receipts afterwards and they will be considered for medications that are covered.
Well, it's good to know you get your money back because medications are very, very expensive. So
you get whatever you pay in excess of your set deductible. That's what you get reimbursed back to you. I just want to emphasize that, right? The deductible has to be satisfied first.
Okay.
Yeah.
My next question for you is, what happens if you lose coverage and you don't have the money to pay?
Yeah, that's we do deal with that. Actually, I dealt just the other day with a patient that a recent transplant recipient, actually from a month ago, when they filled the prescriptions at discharge, they just went through 100%, and then the cost was picked up by the private plan at 100%. Ideal scenario. When they came back for refills, it was rejected. And that was because there was an annual maximum that was reached.
Oh, wow.
That the patient was unaware of.
Oh.
And as a result, they were unprepared. They did not apply to Trillium and they were left with having to pay up front. However, our transplant outpatient pharmacy called me to the rescue and I came and the patient was there with the husband. I got them both to sign the form. I still need a few pieces of information from them, but I'm able to intervene and get them enrolled quickly in the Trillium program. So there are resources out there. I can definitely intervene in these urgent scenarios to help patients out. It's no problem. But of course, ideally, every patient that we come in touch with is enrolled in Trillium, regardless of whether they think they have an ideal drug coverage or not. Because there are situations, as I just exemplified, that require Trillium enrollment.
It better be safe than sorry.
Yes,
you don't want to be
backup plan. It's just a backup plan.
Exactly.
We hear so much with patients that come in for transplant, and we meet with them, and we do a medication history, and we ask them what pills they're taking, and they're like, "Oh no, I have a private plan. I have a really good job. I have a really good plan." Like, well,
that doesn't hurt.
They're also money making entities. They could stop coverage at any time. They could say we don't cover X, Y, or Z medication anymore. Something's going to be excluded from our formulary, or you never know. A company could go.
Anything can happen.
Your job.
Yes, and I've seen situations where the private plan terminated without notice.
Oh my goodness.
That is a disaster. Yes.
So there's no harm. There's no skin off your nose, whether you're a billionaire or not. Apply to Trillium. Have it as like in your back pocket for a rainy day. And then I think, what is it, Lucia, every 18 months they have to renew that application?
Yeah. So if you don't use it, it will just run in a background for 18 months. And after that, they will send a notice of termination to you. Mm-hmm. And then you have an option to then extend the coverage, reapply if you want to keep it up.
Just do it.
Yeah. Mm-hmm. Those are for people like Dipika mentioned that want to have it as backup.
Yes.
But if you're using it, they're not going to deactivate you.
Now, if you are deactivated and, something should happen and you realize, shoot, I do need this. It's been, 4, 5, 6 months and you realize, I actually do need this. Mm-hmm. Can you reapply at that time?
Of course. You can reapply at any given point in time. Okay. Again, keeping in mind that you are to pick your own enrollment date on the application. And that is very important because I'm just going to give you an example. If I need to fill prescriptions today is the 3rd, right? Mm-hmm. And I need urgent Trillium and I decided to apply and I'm going to choose tomorrow's date as my enrollment date. Well, guess what? I cannot claim retroactively for what I paid today because I chose an enrollment date in the future. So that's something to keep in mind.
Why would patients pick a date in the future
then? Because those patients that perhaps don't need, they want to have it as backup. Mm-hmm. So they don't really need. Yeah. Not everybody needs to backdate it, right? Unless you're on really expensive medications and you don't have such great coverage through a private plan, you don't really need to backdate it, right? Okay. But if you need to just enroll as a backup, I would see how people would choose a date in the future.
Mm-hmm. Sure. My 2 biggest lessons learned throughout this journey is number 1, make friends with your pharmacist because you're going to be with them for the rest of your life, basically.
So true. So true.
All of these drugs have interactions with each other and they're the experts. So like you talked about before, don't go switching your medication with talking to your doctor or your pharmacist or both. And then the other thing that I learned is apply for Trillium as soon as possible because like Dipika was saying, things can change. You can have a great job today. Look at what happened last year with COVID.
Nobody knew.
People aren't working. They don't have the benefit plan anymore. And my coverage has actually changed up and down over the years from when I first went on transplant medication. At one point, all I had was Trillium. And now with my wife's plan, we have great drug coverage, but it's always there.
Great to hear.
It's covered, and for the ones that fall through the cracks, that's what Trillium is there for. That's your safety net.
You know what? It's funny that you said that, Charles, because I sometimes like to Google questions because I want to know what's out there that patients learn about or what patients see, because sometimes you're like, oh, this is really, why is everybody asking me about this supplement all of a sudden? And I Google it and there it is, like the top hit. So, like, oh, this is the hot thing.
That's the trending topic.
The trending topic. So I was Googling something today when I was, getting ready to meet with you guys. And one of the points it was on WebMD. Have you guys heard of that site? So WebMD, one of the points that said post-transplant is find a good pharmacist.
See,
there it is.
Post-transplant is one of the points on WebMD. So it's got to be true.
It's very important. Very important. So we've already touched upon it, but basically what we're saying here is you need to have good drug coverage. It's very important because you could be in a lot of problems without it. Correct?
Correct.
Yeah. You know what? This has been very information. There's been a lot of information here shared here, very informative. And I'm so happy that you were here to join me and share this information with those that are watching. Thank you very much for coming out. Anybody else want to say something before we wrap up? Last minute information, tidbits?
We're just happy to be here and to share this information with patients because really, we don't want patients to not consider entering the transplant journey because they're afraid of medications or afraid of drug coverage. Like, yes, side effects will happen. We will help you manage them. If you're a bionic man like Charles, you will get over it. You will,
That's right.
You will stick through it.
You keep
there's ups and downs. There's ups and downs.
Yes, that's correct. And definitely drug coverage should not be an obstacle to transplantation. There are so many resources out there and so many people within the transplant team that can help help you through the process and make sure that you have access to the best coverage out there,
yes.
whether through a private plan or a government program. So many resources out there. So that should not be an obstacle whatsoever.
We're super lucky to live in Canada where we have access to these programs.
That's true.
So true. So true. So Charles, we both know we take an enormous amount of medication. I know for myself personally, I try to, take it all at the same time. And, but after a while, for me personally, it feels like my throat's kind of closing up and I can't, I have to stop, take a break, stop for a few minutes and then come back. So describe to me how it is for you taking the amount of meds that you're taking right now.
Yeah, absolutely. You have to have a game plan. I think somebody mentioned that it's kind of like a meal. And I have one of those pill minders, the different colors for every day, 4 sections, little box. Today's Wednesday, which is green. And so, I just got done sorting my meds for the week. I didn't do my pill count, so I don't know how many pills I'm up to per day. But I learned that I have a morning, an afternoon, an evening, and a night set of pills that I take. And in the morning, I used to try to take them all at the same time. But then over the past year or so, I noticed that I started getting nauseous after I took them that way. So I decided to, actually, one of my pharmacists said, hey, why don't you try splitting them up? And then it's figure out which one of the pills is actually causing you to be nauseous. Yes. So since I've done that, I can tell you, exactly. I take my doxycycline, my pantoprazole, my amlodipine, and my vitamin D and calcium all in one time. Then I take my 4 program pills. After I wait about 10 to 15 minutes, then I'll go back and then I'll take the rest of them, split them up that way. And that's the only way I can do it. And that's taking away that nausea. But it's kind of a mental thing. You know that you have to take it. It's not enjoyable, but you have to do it if you want to stay healthy. And the way I always looked at it kind of overall philosophically is once you get a transplant, you signed a lifetime contract. You're going to have to take medication for the rest of your life. But it's a very small price to have to pay to have a rest of your life.
Thank you, Charles. I couldn't have said it better myself. I feel the exact same way. I mean, I used to be I did the same thing as you did, which is basically try to take them all at once, take my morning pills all at once. But after a while, it's like, okay, this isn't working. It doesn't feel right. So I'm not supposed to feel this way. So, I did the exact same thing you did, which is just basically, space them out and see which one was making me feel that way. And now, thank goodness it's all worked out. But yeah, you're right. This is the smallest price we have to pay so we can have a healthy life. We didn't go through this whole process to get this transplant and then not do what's necessary. So well said, Charles. Well said. Well, once again, thank you very much for coming out. I'm so happy you joined me on the Green Table Talk. Please feel free to come back again anytime. Thank you very much for taking the time out of your day for being here. And as always, before I end the show, I'd like to put out a little tidbit, a little piece of information to the viewers. For today, the tidbit is this. Don't try to be anybody else. Just try to be the best you that you can be. That is it.
Beautiful.
Thank you for joining us on the Green Table Talk. Please come back again next time. Take care. Bye-bye.